Thank you, Dr. Meena and Sanita. No financial interest. We have 1.4 million blind children worldwide and 19 million visually impaired children. That means the magnitude of the problem of visually impaired is much more than the blindness. Of the childhood blindness, about 75% of these conditions are preventable. And what we see today, the children who access the hospital with ophthalmic care facilities are just a fraction of the total number of blind and visually impaired people we have in the community. Here lies the relevance of a community screening program where we detect children with low vision or blindness, and the most important cause of low vision in these children is amblyopia, which have to be picked up early because whatever is lost irrecoverably, and we have to pick up these amblyopes quite early and detect the cause and treat them so that they could be brought into the world of light. Whom do we screen? Of course, the school children, because in a state like Kerala, where we practice, all the children are school going. There are very few school dropouts. So we target mainly on the school children. Then we have the special school children, the children with multiple disabilities, the preschool or the Anganwadi children, and the underprivileged children or orphans. I'll take you through the experience of our hospital over the last few decades in combating this problem of childhood blindness. The school screening program was started by a hospital way back in the 1980s, and it became a regular program in 1993. As of now, we have a three-tier pyramidal model where the initial screening of these children for visual disabilities is done by the teachers. We train the teachers in picking up poor vision, visual disability and blindness, and those screened are then brought to a free eye camp where under the care of an ophthalmologist they are evaluated and found out for what they need treatment, and then as a third level they are brought to the tertiary eye care hospital where a detailed evaluation and treatment is done wherever possible. This is the protocol which we have. Those patients with 6'9" or less are seen by the ophthalmologist. 6'9" or better are seen by the ophthalmologist and treated at the campsite, while those with less than 6'9" are in fact brought to the hospital for treating their conditions. They're done a full examination in the hospital and they're treated. This is how we go about with the school screening program. We screen all children to find out whether they have a normal vision or a subnormal vision. It has to be done in a place where there is adequate light and adequate space with 20 feet distance. The children have to be demonstrated on how to use the e-chart and screen using e-chart. The senior students of the school are trained in helping out the teachers with vision testing. The chart is made to be read by the children, and those children who have been picked up as visually impaired are in fact given pamphlets or given adequate information so that their parents would also be educated about their condition, and the children are brought to the hospital and treated. The numbers which we need for a school with 500 students, we need only one teacher for the screening. For a school with more than 500 students, we train 2 teachers. Screening at the campsite includes a cycloplegic refraction and a torchlight examination and ophthalmoscopy. Once they are brought to the base hospital, they are evaluated by the pediatric ophthalmologist and spectacle is given free of cost, and surgical procedures, if any, are given at a subsidized rate for all these children, and for the really needy it's given free of cost. We have local collaborators for these programs, and many of these collaborators, they are more than happy to help us in treating children with childhood blindness, because for most of them it's an appeal, childhood blindness. So we approach the local collaborators for funding of treating of these patients. In 1 year we could hold 103 screening camps after those which were screened by the school teachers. We examined more than 20,000 children, and about 30% of these children were diagnosed with ocular disorders. About half of these patients could be treated at the campsite itself. Most of these were refractive errors, and the other half were brought to the base hospital for treatment. This was the breakup of the ocular diseases, ocular disorders in fact, which we could pick up from the school screening program. More than 70% had refractive errors, and all the other diseases together accounted for 30% of these disorders. The merits of these model, this is a cost-effective model. The screening tests are reliable and sensitive because this is done using a Snellen's chart. The teachers are the most reliable people in the community. They are very much concerned about the health of their wards, and timely recognition of defective vision will help us in reducing the incidence of amblyopia in the community. What are the inadequacies of the model? We had quite a few false negatives. Compliance issues. The children might go to their homes and tell their parents, but the parents, they don't want to waste one day's wages and come to the hospital for treating their children. And many of them had financial issues. Though the treatment in the hospital was given at a highly subsidized rate or free of cost, the parents might find it difficult to come to the hospital, wasting one day's wages and also spending money on transport. Now, we also screened schools for the visually impaired. We had 7 schools for the visually impaired, the blind schools, which we call them, in the 4 central districts of Kerala. And the children from these 7 schools were screened for the various eye diseases. 158 children were there in these blind schools, which represents almost half of the total blind school population of Kerala. And the mean presenting visual acuity was 2.92 logmark. The mean age of these children were 10 years. Most of these were boys. These were the various screening tools which we used in screening the blind school children. These children, we had the census done in these tools. Then we went through the demographic data, did a visual assessment, general assessment, history of previous eye surgery, and eye examination per se, refraction and low vision assessment, and the etiology of the visual loss. The distribution of the visual loss, half of the children had serious visual impairment, and this is the etiology other than the refractive errors which we could go through. And most of these children had optic atrophy. About 18 children had ROP, which was not detected at the right time and treated. Of the avoidable blindness, preventable causes accounted for about 25% and treatable causes for 15%. Of the preventable causes, we had ROP, rubella, corneal infections, and of the treatable causes, we had cataract, amblyopia, refractive errors, and corneal opacity. And how do we rehabilitate these children? We give them low visual aids for those for whom any sort of treatment was not feasible. Free spectacles and free low visual aids were distributed, and we evaluated them in detail in the base hospital. 42 children required visual rehabilitation, of which 28 required spectacles, 21 required low visual aids, and 14 patients required surgical intervention, and 1 child had a learning disability. From the surgical rehabilitation, this was the breakup. We had cataracts, secondary IOL, membranectomy, yak capsulotomy. Most of these were related to cataracts. And we had a few of them who had to undergo keratoplasty. Our retinopathy of prematurity screening, which was dealt with in detail in the last instruction course just half an hour back, this was done in a hospital from 2007 onwards. The total screened children till date has been about 1,000, and 50% of these children had no ROP, while 50% had ROP. This includes both the screening in the neonatal ICUs as well as those children who are referred to the hospital with suspected ROP. And this has been the number of ROPs which we screened and treated over the years. The outreach program we had for 2007 and 2008, this was the statistics. Screening of children with multiple disabilities, we screened about 125 children, and 28 were referred to the tertiary care center. 7 had surgery advised, and the rest had optical rehabilitation or low visual aids. And the lessons which we have learned from this screening program over the years is that community outreach is the key in eliminating avoidable blindness. We don't expect the blind or visually impaired children to report their blindness and come to the hospital. So we have to go to the community and we have to be proactive. And also we have to have a focus on underprivileged children who might not turn up to the hospital at all in spite of their being diagnosed as having a visual impairment. The challenges, we have to ensure the compliance in these patients. We have to ensure the follow-ups which are mandatory. Here also we can utilize the services of the school teachers, and advocacy and policy implementation need to be strengthened. Before I conclude, let me invite you all to the Vitreoretinal Society of India annual conference which we are conducting in Kumarakom, Kerala in December 2015. I welcome you all to this conference. Thank you.